Hello, my name is Naval. I'm a associate professor in the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. Today, I will be discussing what is new in immunotherapy in acute myeloid leukemia. There has been a lot of progress in understanding the immune microenvironment in acute myeloid leukemia, and over the last 5, 6 years, we've seen evolution of different immunotherapies. Now, when we think about immunotherapy in acute myeloid leukemia, we're thinking about two different modalities. So one of them is what we call antibody-based therapy. So these are antibodies that are targeted towards the surface of particular antigens expressed preferentially or uniquely on the surface of acute myeloid leukemia cells, and these antibodies will attack and link to that antigen and result in death of the leukemia cell by delivering a toxin. And this is an approach we have used for many years in acute myeloid leukemia. There is a drug called gemtuzumab ozogamicin that is approved for the treatment of AML, both in frontline and in relapsed AML, that uses a antibody drug conjugate approach with a bacterial toxin that is delivered to the leukemia cells preferentially, causing death of those cells and remission of the leukemia. And there are many other antibody drug conjugates that are in development targeting other leukemia AML specific antigens like CD123, CLL1, and others. And some of those are in clinical development. One of them that is in advanced development is a drug called IMGN. This is a antibody drug conjugates to CD123 on the surface of leukemia cells. And here we use a chemical toxin instead of the bacterial toxin used in gemtuzumab. And that study is showing encouraging activity both in acute myeloid leukemia and in a related disease called BPDCN. Now, on the other hand, there's a whole arena of different novel immune therapies that use the body's own immune system called the T cells or NK cells or macrophages and harnesses those or activates those to fight more actively against the tumor. So normally in our human body, our T cells, macrophages, NK cells should recognize any foreign antigen that should not be there and should mount an immune attack response towards them and eradicate them. And that's usually what happens when we get infections, viruses, and that's how our body overcomes them. However, cancer is able to actually shut down the T cell macrophage defenses by using particular proteins on the surface of these cells called checkpoints. So the cancer actually activates these checkpoints and will shut down the T cells, macrophages. And so we can actually see in biopsies that there are many T cells and macrophages in the tumor and they are not responding or fighting against tumor. So we have developed now over the last 10, 15 years drugs that can block the ability of the cancer to access those immune checkpoints and keep the T cells and macrophages active so they will continue to mount the anti-tumor response. And there are many of these immune checkpoints that have been identified: PD1, CTLA4, TIM3. In AML specifically, there's interest in looking at PD1 inhibition with nivolumab, CTLA4 inhibition with ipilimumab, and most recently, there's a new target towards TIM3 drug called sabatolimab, which is showing quite encouraging early activity in frontline MDS and AML. And so these trials are all ongoing. But more importantly, what's happened in the last 2 to 3 years in AML, which is very, very exciting, is we have started understanding that if we activate macrophages by blocking CD47, which is a macrophage checkpoint, we are getting very, very high activity. So in frontline AML, the combination of this macrophage blocking antibody, which increases the macrophage activity with a traditional AML drug, azacitidine, is showing us almost 65-70% responses, 2 to 3 times higher than we would get with azacitidine alone. And this looks like it may be the most effective immune therapy, immune strategy today in acute myeloid leukemia. And hopefully next year, maybe a drug that could potentially go for approval and be available. Many studies ongoing with this, very, very exciting. And I think there are many other approaches like bispecific antibodies that also link to T cells on the surface of the CD3 on the surface of T cells and markers on the surface of AML cells, and they bring the T cells close to the AML cells, resulting in their death. So all in all, I think in the last 6, 7 years, we have seen a major emergence of immunotherapies. Still a lot of work to be done, but we definitely know much, much more than we did before. There's about 20 times more trials than there were 5 to 6 years ago. And I think over the next decade, we will find more and more application of immunotherapy in acute myeloid leukemia. So look out for all of these clinical trials that are ongoing and coming in the near future. Thank you very much.